My name is Dr. Joshua Sonnen, and this is a lecture on brain cutting. You've waited 7 to 10 days for the brain to fix in formalin so that it is sufficiently firm to cut. During that time, you can do several things to prepare for brain cutting. You can make sure that you have a complete history of the patient. Check imaging. This is very important because modern imaging techniques are actually quite a bit more sensitive than standard brain autopsy for small lesions. And so you want to make sure that you're looking for every abnormality that has been noted on imaging. And then review of the PAD to see what systemic illnesses might have had effects on the brain. Now there are a number of different ways to cut a brain. I'm going to describe a standard method that is useful for the vast majority of adult brains. We're going to cut the cerebrum in a coronal plane, the brainstem in planes perpendicular to the neuraxis, and the cerebellum in radial planes that intersect through the line of the neuraxis. Now this sounds a little complicated, but we'll have diagrams throughout the presentation that hopefully will make it abundantly clear. Now I want to introduce a concept from cooking to our dissection. The concept is called mise en place, and essentially it means that you have everything in place and within arm's reach to do your cooking, or in this case dissection. So the first thing that we have are a number of pre-labeled cassettes. At the top of the cutting board you can see one of the beautiful Sakura tissue tech knives that cut brain wonderfully. There is a smaller scalpel for closer work, forceps, a probe, and a pair of scissors. So I like to go through the brain a piece at a time so that I can focus on each individual element and then synthesize after I've completed the dissection. So this is the cap-shaped piece of dura that you'll generally receive with your brain. It has the falx in midline and also contains the superior sagittal sinus. Now you want to look very closely at the convexities of this dural cap to look for any membranes, any tears, any surgical sites. Then we're going to investigate the superior sagittal sinus. You'll fold the dura and from the outside, using scissors, make multiple cuts through the superior sagittal sinus, and then you can look inside to see if there's any thrombus or abnormality. You also should generally receive a pituitary gland in a cassette. Pituitary gland should be cut in a specific manner. The white arrow here shows the pituitary stalk, and you want to cut the pituitary in a sagittal plane. Now you may have difficulty orienting the pituitary. The easiest thing to remember is that the pituitary is wider in the mediolateral plane than it is anterior to posterior. So you'll make a couple of cuts and then use the central section for histology. If you cut it correctly, this is what the pituitary should look like. The stalk is marked, and you should be able to see both more whitish areas and more grayish tan areas. The whitish areas are posterior or neurohypophysis, and the other areas are the adenoglandular anterior hypophysis. So now, just very briefly, I'd like to go over some basic neuroanatomy. Here's a cartoon of a brain. We're going to focus on the cerebrum first. So that's the everything above the tentorium and includes multiple lobes of the brain. So the lobes that we think of are the frontal lobe in light blue, parietal in dark purple, or in light purple, temporal in green, and occipital in yellow. Below the tentorium, the cerebellum is in orange, the pons in teal, and medulla in gray. So now we have our real brain. Now the first thing that you should do with the brain is weigh it in its entirety. The average brain weighs between 1,200 and 1,500 grams. Now I have to say this doesn't look all that much like the cartoon, and it's because it's covered with the arachnoid meninges. The arachnoid meninges can be removed to show more closely the surface of the brain, carefully with forceps and then cutting away at blood vessels as you encounter them. This should be done mainly in cases where there is a suspected neurodegenerative disease and you're looking for cortical atrophy. Otherwise, you don't need to remove it. However, by removing the meninges, I think you actually get a better look at the cortical surface. You can see the folds of cortex called gyri and the valleys between them called sulci much more readily. In this case, you could actually fit, say, a butter knife in between the sulci here, and that suggests that there's a small amount of cortical atrophy in this case. You will have received the brain generally such that there is a bit of cotton string tied around the basilar artery. This was used to suspend the brain within a bucket of formalin. You should remove this with the scissors, and then we can proceed. So here we are at the base of the brain, and we're going to take just a minute now to go over some of the basic anatomy. First, let's go over the cranial nerves that can be easily found at the base of the brain. We'll start with the olfactory bulbs. The olfactory bulbs sit on the inferior surface of the mesial frontal lobe and project out over the ethmoid plate. Posterior to this are the decussating optic nerves. Arising at the base of the midbrain, just superior to the pons, are the oculomotor nerves, coming out close to midline. Laterally, at the base of the pons, arise both the facial nerve, which is a smaller, thinner nerve trunk, and a somewhat larger vestibulocochlear nerve appearing laterally. Now we have a closer image to look at the arteries within the circle of Willis and at the base of the brain. Now, if you have any question that there is a vascular abnormality, especially an aneurysm or occlusive disease causing a large cerebral infarct, you should go ahead and dissect off the arteries of the circle of Willis so they can be more closely examined. Here I've highlighted just some of the larger arteries as landmarks. The carotid arteries are present at the base of the brain, just lateral to the optic chiasm. The basilar artery runs along the midline pons, and the vertebral arteries surround the medulla. You'll notice in the basilar artery that there is some yellow thickening of the wall, and this is atherosclerosis. The amount and occlusive extent of atherosclerosis should be noted. Now we're looking at the superior surface of the brain, downward, and there's a couple of things that you should note here. One of the most important concepts in neuropathology is to look for basic symmetry, and the brain is symmetric here. You want to open up the sagittal fissure of the brain and look for first the anterior cerebral arteries. But you also want to see if you can see the corpus callosum, because if you can see the corpus callosum, then you're not concerned about subfalcine cingulate herniation, which we do not see here. We can nicely see the corpus callosum. Once that's accomplished, we're ready to remove the contents of the posterior fossa and start cutting the cerebrum. This is one of the more challenging techniques for people learning to cut brains because it's a blind cut. You're at the level of the midbrain. You basically lay the scalpel on the surface of the brain and then bring it in about deep to the brain about a centimeter and slide across. If you're successful at this, you should reveal the mammillary bodies and a section of midbrain. Here we can see the two red nuclei and a little bit of the substantia nigra, so you're right in the middle of the midbrain. This will also allow you to see the arteries of the posterior circulation of the circle of Willis more closely. You also want to look for evidence of uncal herniation. Now, the uncus is a little portion of the temporal lobe that lies just medial to the tentorial notch. If there's been any brain swelling, this is a place that the brain will herniate. You want to look at the uncus, find where the notch, where the uncus lies on the tentorium is. Here I've highlighted it with a dotted line. And then measure the distance from that line to the medial extent of the uncus, and note that. Significant uncal herniation doesn't have a specific size. Certainly any necrosis of the uncus is diagnostic of significant uncal herniation, but there can be non-necrotic uncal herniation that is also clinically significant. Here I'm highlighting the mammillary bodies because this is where you're going to target your first cut. We're going to cut a coronal cut all the way through the brain using that long Sakura tissue tech knife. And the way that you should perform this is in a single stroke with a lot of motion of the knife and not much pressure. This will give you the cleanest and best cut possible. Here's that plane that you're going to be aiming for. After you've made this cut, you'll have the brain separated into an anterior and posterior portion, and then you're going to start making coronal cuts through the brain at about a centimeter interval, and lay out the brain in such a way that its right is on your right to help keep track of which side is which. You will be making a cut at the level of the temporal tips, shown here. This is an important cut to stop and note because you should not normally see any of the anterior horn of the lateral ventricles present at this section, as we don't see it here. If you do see it, it suggests either hydrocephalus or hydrocephalus ex vacuo, and you should measure the greatest diameter of the lateral ventricle present at this cut. Now we're going to go through a leisurely tour of the sections that you will have cut from the brain. This is a frontal section, and once again we're going to stress symmetry. So the brain should be reasonably symmetric, and when we're investigating cerebrum, we have an external cortical gray ribbon that is 3 to 4 millimeters thick, and central white matter. The central white matter should be basically homogeneous, with only small vessels seen running through it. Now I've put in a cartoon of where the eye sits in the head in order to highlight the convex nature of the orbitofrontal cortex. This can just help you orient yourself to being in frontal cortex if you're having to go back to a bucket and try to orient all the cortex again. Here's one more posterior section where we're getting into the temporal lobes. Here now we can see a portion of the lateral ventricle and the anteriormost portion of the corpus callosum called the genu or knee. You'll note that the anterior cerebral arteries here are wrapping around that genu to feed the midline cortex of the frontal lobe. Here's one more posterior section. Now we've started to get into deep gray matter structures, or here the basal ganglia, also called deep ganglionic masses. I'm pointing to the head of the caudate that sits here on the floor of the anterior portion of the lateral ventricles. The lateral ventricles normally have a pretty sharp lateral angle. Here it's a bit rounded, so there probably is a little bit of hydrocephalus ex vacuo, and that goes along with the mild cortical atrophy that we saw earlier in this case. You'll also note now that the middle cerebral artery is present within the sylvian fissure, or the fissure that's present between the frontal lobe and temporal lobe. I've highlighted a standard section that I usually take from every normal brain. This is a section that in the coronal plane that includes both the superior and middle frontal gyrus. This is a watershed cortex and is an area that is at risk for ischemia. Now we're in a section slightly more posterior, still showing primarily the frontal lobes and temporal lobes, but now we've gotten into far enough into the basal ganglia where there's both the caudate and putamen separated by the internal capsule. And then arising in the deep gray matter, I've highlighted the anterior commissure. Now this white matter structure is a helpful landmark for the next section that I usually like to take, and that's a section of basal ganglia. Basal ganglia is a good section to take for a couple of different reasons. It is a nice place that showcases hypertensive injury to brain. It's also a location in which you can see changes of a metabolic nature, and I'll talk about that later when we talk about in another lecture when we talk about metabolic astrocytes. Also, I've highlighted in this section a gray matter structure in the anterior temporal lobe, the amygdala, which I personally think is a little bit hard to find. It's supposed to be almond-shaped. I'm uncertain whether I can see that or not. In the next section, we can talk a little bit more about the lateral ventricles. So the lateral ventricles are sitting underneath the corpus callosum, now the body of the corpus callosum, and are separated from one another by a thin membrane called the septum pellucidum. We've now gotten far enough posterior that we are also looking at the communication between the lateral ventricle into the third ventricle through the foramen of Monroe. At the base of the third ventricle are the mammillary bodies here. We are also now far enough posterior into the temporal lobe that we can see the anterior portion of the hippocampus, also forming the medially. This is what forms the uncus. Now, the anteriormost portion of the hippocampus, you can see that the cortex is quite wiggly. This is the portion of the hippocampus that's called the pes inserinus, or duck's foot. Now, we can go back and look at the body of the caudate, separated by the internal capsule from putamen, and now medial to the putamen is the globus pallidus. Now it's called pallidus because although it's a gray matter structure, it's somewhat more pale than other gray matter structures, and that's because it contains a lot of myelinated fibers, white matter. Now in the next section, we've actually centrally gone into the thalamus, and in the middle of the image you can see actually the anterior portion of the thalamus and the third ventricle. Below the thalamus are two gray matter structures called the red nuclei. And this is an interesting coronal section because it's a good place that we can now estimate what's called downward herniation of the brain. So, in general, if these red nuclei, here highlighted by teal circles, if those are at least halfway above a plane that's resting across the tops of the hippocampi, in our red line here, then you don't have to worry about that the brain is downwardly herniated, that it's swollen so much that it's been pushed downward through the tentorial opening. And in this case, that is also true. The next level, we now see a well-developed thalamus and third ventricle, and actually between the bilateral thalami you can see a little mass gray matter touching across, and that's called the massa intermedia. We've also gotten back far enough in the temporal lobes that we're now at a nice section of hippocampus to take for histology. And we have a nucleus at this level called the LGN, or lateral geniculate nucleus, that's part of the optic tract, or it's the end of the optic tract, that serves as a landmark for a nice section of the hippocampus where we can easily find those sections of the hippocampus that are most susceptible to hypoxic injury. So here I put my little red box again for another area that would be nice to cut in. Now we're far enough posterior that we're almost out of the thalamus. We're in the posterior-most thalamus, an area called the pulvinar. Pulvinar comes from a word meaning pillow. I'm not really sure how these resemble pillows, but they certainly are at the most posterior part of the brain. And we've also gotten back out of the third ventricle and now are seeing the pineal gland in the midline. In the next section, we can see what's called the trigon of the lateral ventricles, a large area of CSF containing space. And here there's a large mass of choroid plexus. Actually, we've been seeing choroid plexus in the lateral ventricles all through this dissection, but the largest single mass of choroid plexus is present here in the trigon. Also, the white matter centrally is the end of the corpus callosum, called the splenium. And we're now surrounded by getting back into the parietal lobes. At this section, we can no longer see a separation between the upper and lower portion of the brain as you do in the frontal and temporal lobe. And so we really are getting into the parietal lobes superiorly and occipital lobe inferiorly. This section, near the end of the lateral ventricles posteriorly, we can see a fold of cortex that's called the calcarine sulcus, or calcarine cortex. This is the primary visual cortex. And calcarine has to do with a rooster's spine. There's something about the shape of this cortex that reminded early neuroanatomists of a rooster's spine. I have a picture insert that I don't think looks especially like this cortex, but well, there it is. Now, the calcarine cortex is also called the striate cortex. It's the only place in cortex that has any inhomogeneous coloration. And here there's a little white stripe right down the middle of that gray matter. And it's difficult to see on this image, but it's something you should look for in gross dissection. Now here are our last couple of coronal sections of brain. We can still see calcarine cortex in the midline. Now we're almost entirely in parieto-occipital lobe. So now we can focus on the contents of the posterior fossa. So here is the brainstem and cerebellum, and I've highlighted a few landmarks that we can go through. So the superior-most portion of this photograph is the midbrain. Arising in the midbrain, right above the pons, close to the midline, is cranial nerve 3 on both sides. Then there's the belly of the pons. Right in the middle of the belly of the pons, laterally, is the origin of the trigeminal nerve, a very large nerve bundle. Below the pons near the midline is cranial nerve 6, and then laterally are cranial nerves 7 and 8. Here we are at looking at the posterior fossa contents from below. In the midline, the cerebellar cortex is called the vermis, which means worm. I suppose it resembles a worm in some way. In the midline near the medulla are the cerebellar tonsils. This is the tissue that will herniate down through the foramen magnum if there's global edema. You want to see if the tonsils are compressing the medulla. They'll have become rounded with the shape of the medulla. Here they are clearly not. And you also want to see if they are extruding upwards past a groove made by the foramen magnum, and you'll measure that bilaterally. To dissect the contents of the posterior fossa, I recommend removing the cerebellum and cutting it separately from the brainstem because I think they're better visualized in different axes. The first cut that you will make is another blind cut through the midline vermis and down into the fourth ventricle. Here I've included a line showing you right where to cut. I would recommend using the smaller scalpel for this the first few times. Here I've cut into the midline's cerebellum and opened up into the fourth ventricle. You'll now want to make lateral cuts using gravity as a retractor to remove the cerebellum from the cerebellar peduncles. Here I've removed one side. You can see the middle cerebellar peduncle. I've opened up into the fourth ventricle. Our cranial nerves are now even more apparent. For the first time you can see the trochlear nerve wrapping around from the back of the midbrain. Cranial nerve 5, the trigeminal, is seen arising nicely in the middle of the pons, and cranial nerves 7 and 8 are seen from the base of the pons. This is also a very attractive cut through the midline vermis of the cerebellum and reveals the structure that is called the arbor vitae, or tree of life. After both cerebellar hemispheres have been removed, you'll have a brainstem with an open fourth ventricle. You can once again visualize very nicely cranial nerve 4. You'll make a number of sections about half a centimeter apart from the midbrain all the way through to the spinal cord if you have some attached. The cerebellum is now ready to be cut, and as I said, this is going to be radial to the line of the neuraxis. So this is what I mean. And you should be able to get about 5 sections out of the cerebellum in this manner. Once you've performed this, you should be able to line up nicely the cerebellar hemispheres and the brainstem for examination. So now we're going to take a brief trip through some of the more important sections of the brainstem. Here I've got a section of the midbrain. The large white matter structures ventrally are the crus cerebri. Deep to those is the substantia nigra. Substantia nigra should be well pigmented in adults and have a ventral and dorsal tear. This one I think you can see both, so that's probably normal pigmentation. Cranial nerve 3 is seen exiting the midbrain medial to the crus. We're at the point in the midbrain where there's the aqueduct and tectum. This is a section from the middle of the belly of the pons. Ventrally you have the large basis pontus, which has prominent white matter fibers crossing to the cerebellum. Dorsally there's gray matter, and the most superior portion of the third ventricle, and another pigmented nucleus, the locus ceruleus. The level of pigmentation should be noted. Now we're looking at the superior medulla. In the superior medulla, things are relatively small, and so it's a little more difficult to visualize the individual structures without magnifying aid. But you should be able to recognize the medullary pyramids and the inferior olivary nuclei ventrally as two distinct bumps. Here we can still see the medullary pyramids in a more inferior portion of the medulla, but it's more difficult to discern other structures. And finally, we've gotten into the superior spinal cord. Here's a section of the midline cerebellum. You want to look at the vermis, the superior portion, and see if there is any evidence of atrophy, if there's any space between the individual leaves or folia of the cerebellum, and if so, it's a good section to take. Here's a section of the lateral cerebellum. I've included a rectangle to show an area that I like to sample. It's important to sample cerebellum because the Purkinje cells of the cerebellum are exquisitely sensitive to hypoxic injury. Centrally there's white matter, and then you can see a kind of wavy gray matter structure, and that's the dentate nucleus. Thank you very much for your time and attention. I hope that this will be helpful. You have reached the end.